Welcome to The Explainer. Today, we're going to talk about something that affects, well, pretty much all of us, blood pressure. We're going to trace the fascinating and sometimes pretty controversial history of how we even decide what high blood pressure is. The goalposts have shifted so much, and understanding why is key to understanding your own health.
All right, let's just kick things off with one number that ought to get your attention, 90%. What on earth could that be?
Yeah, you heard that right. Even if you have totally normal blood pressure at age 55, there is a 90% chance you will develop high blood pressure at some point in your life. So this isn't some topic for other people, it's for basically everyone. And that's why getting these guidelines right is so incredibly important.
Okay, so for a long time, if you were a doctor, you had a very clear playbook. It all came from a landmark document published way back in 2003, known as JNC7. This was the Bible for blood pressure.
And you know what? It was kind of beautiful in its simplicity. You had these 4 clear-cut categories. It even gave us the word pre-hypertension, which was a great way to flag people who were heading for trouble. And for most patients, the goal was simple, universal. Get your numbers below 140/90. That was it.
And the treatment? It was often just as straightforward. This was all backed up by these huge powerhouse clinical trials, like the All-Hat study, which basically concluded that starting with a simple, super cheap water pill, a thiazide diuretic, was the best move for most people. The path was clear.
But then, 2014 happened. And the playbook? It didn't just get an update, it basically got thrown out the window. The next version, JC8, dropped, and it created a major firestorm in the medical community.
And here's the part that really threw everyone for a loop. You'd think new guidelines would get stricter, right? Nope. For adults over 60, JNC8 actually relaxed the goal, recommending a target of under 150/90. It felt totally backwards to a lot of doctors.
So what was going on? Well, the panel behind JNC8 was, let's just say, very strict. They decided they would only look at the absolute gold standard of evidence, randomized controlled trials. And in their view, there just wasn't enough rock-solid proof that pushing blood pressure lower in older adults was worth the potential side effects. The result? Total confusion.
So, you had this big debate raging for a few years. And then, in 2017, the cavalry arrived. 2 of the heavy hitters in heart health, the American College of Cardiology and the American Heart Association, teamed up. They released a new, massive set of guidelines that finally settled the debate and gave us the modern approach we use right now.
So, the first thing they did was completely redraw the map of blood pressure categories. That old pre-hypertension zone, gone. Now we have elevated and critically, stage 1 hypertension now kicks in at just 130/80. And just like that, literally overnight, millions more Americans were suddenly classified as having high blood pressure.
But honestly, redrawing the map wasn't even the real headline. The most profound shift, the real game changer, was this. It's not just about your number anymore. The decision to start medication is now all about you, your personalized risk of having a heart attack or stroke in the next 10 years.
So here's how your doctor thinks about it now. It's a much smarter 3-step process. First, they see what category your blood pressure falls into. Step 2, they plug your info into a risk calculator. And only then, for step 3, do they combine those 2 pieces of information to figure out the right path for you.
And this is where it gets really interesting. It means 2 people can walk into the doctor's office with the exact same blood pressure, say 135/85, and get completely different advice. The person with a higher 10-year risk might start medication, while the low-risk person will focus on lifestyle. It's all about context.
Okay, so we've established it's all about personal risk now. But what does that mean for the actual medications you might take? How's that changed?
Well, that old idea of everyone gets a water pill first, that's out. Today, we have this whole toolkit, 4 different classes of drugs that are all considered great starting points. This gives doctors a ton of flexibility to pick the right drug for the right person.
They also got more aggressive for people with higher numbers, that stage 2 category. For those folks, the recommendation is often to start with 2 different meds right off the bat. Why? Well, big studies showed that hitting the problem hard and fast from 2 different angles just gets blood pressure down more effectively.
But, as anyone with high blood pressure knows,
it can be a stubborn beast. So what happens when even these new, smarter strategies just aren't enough to get the job done?
And this is a really tough spot to be in. It's a serious challenge that a lot of patients and their doctors face, where the numbers just won't budge.
There's actually a clinical term for this. It's called resistant hypertension, and the definition is pretty specific. Your blood pressure is still above the goal even though you're on 3 different kinds of meds at good doses, and one of them has to be a diuretic. It also counts if you need 4 or more drugs just to get to goal.
But before a doctor officially slaps that resistant label on you, they have to do some detective work. They need to rule out what's called pseudo-resistance, things that look like resistance but aren't. We're talking about stuff like white coat syndrome, where your pressure just spikes in the clinic, or maybe an over-the-counter cold medicine is interfering. There's a whole checklist to go through.
So when you step back and look at this whole story, from the simple rules of JNC7 through the big controversy of JNC8 to where we are today, you see something amazing. You see medicine learning, evolving, and getting smarter. And it means the most important question we ask about our health has changed.
And that right there is the crucial takeaway. The modern conversation is not just about one number. It's about knowing that number within the context of your overall risk. The question isn't just, what's your blood pressure anymore? The real question is, what's your blood pressure and what's your risk? Knowing both is the key to taking control of your future.